Yes, yes.
Wonderful. Yes. Okay, so today's case, everybody, is a good one. Interesting antenatal care, and then yeah, well, you'll find out about the outcome of this baby. Perfect, let's get started. So some of you may be familiar with this case, I'm not sure, but this lady is a Gravida 2 Para 1. She had an SVD in 2017, which went well and all uncomplicated. Medical history is an appendectomy, and she had a BMI of 25. Limited English, she spoke Romanian, and she did have language line used for all of her antenatal care, which was really good. 30 weeks, she was seen in triage following her growth scan due to SGA being on the 2.5th centile at the time with normal fluid, liquor and Dopplers. She had a torch screen done, which all came back negative, and had follow-up day assessment unit appointments due to her SGA baby. DNA'd a couple of appointments with DAU just due to childcare issues, and one follow-up with a consultant, but was later seen by one. 35 weeks, following on from her ultrasound scan, due to the fact that the baby was still on the sort of 2.5th centile, she was offered an induction at 36 weeks. However, this kind of fell around Christmas time, so she declined it and asked for it to be postponed. This induction was offered by one of our midwives in antenatal clinic, but she didn't have a consultant or obstetric review following on from this scan. And then they essentially repeated that was the Doppler scan, sorry, and then they essentially repeated the growth scan at 36 weeks. The ultrasound was done by one of our fetal medicine consultants just due to the high risk of IUGR, and it was confirmed that this baby was due to be IUGR under the 1st centile. So an induction of labour was booked for 37 weeks, and unfortunately she didn't have any didn't have any obstetric follow-up after this ultrasound. Her bacteriology came back as her having cytomegalovirus. And she wasn't offered a cesarean section in this pregnancy. I think she was keen for an induction of labour, and that was always the plan. So she came in on the 27th of the month. This is her initial CTG that we've got here. Oh, sorry, Miss. Yeah, go on, Mr. Naguib.
Yeah, so just to like put things correct in the sense of whether we see it as a deficiency or not. I think following the Saving Babies' Lives. So just to give some background, obstetric background to everybody in the call, really. Saving Babies' Lives, if you are between the 3rd and the 10th centile, you should be induced between 37 or 30 to 39 weeks. No, not induced, delivered. Delivery can be according to the discussion of induction versus C-section as anybody else in the pregnancy. Number 2, if you are below the 3rd centile, according to Saving Babies' Lives, you should be induced at, you should be delivered at 37 weeks. Delivery, again, according to the discussion of C-section or induction of labor. Once the Doppler is normal on the scan at 36 weeks, for example, 36 and 4, 36 and 3, whatever, you don't need any scans or follow-ups obstetrically between in this few days, really. You are induced at 37, but you are advised, or what they call it, safety netted, to come if you are not feeling the baby move and so on. So from that point of view, till that point, I mean, so far, if I'm looking at the case prospectively, not retrospectively, everything so far has been followed routinely. And according to the guideline, the only thing, if the discussion, as I said to Cara before, of C-section or not, and we cannot find it in the notes clearly, that it was documented. So, but everything else has been followed according to the guide.
Thank you, Mr. Naguib. Always good to have a bit more background when it comes to these sorts of things, specifically from an obstetric point of view. Perfect. So this was her admission CTG. So due to the fact that she was IUGR under the first centile, the plan was made for her to be induced on our labour ward, as we would normally do for babies on a very low centile estimated. But just while the acuity was high on labour ward and nobody could take her, she had a couple of CTGs performed on our Hope ward, just to make sure that everything was fine with baby and give a good background prior to starting the induction of labour. So this CTG met criteria at 26 minutes. As you can see, all looks very well in terms of this CTG. We've got some accelerations, and we do have what looks like some uterine activity here, but it wasn't commented on this CTG. I don't believe the client was in any discomfort at this point, so this was kind of ruled out as being anything contraction-wise. This was a little bit later on. Again, Dawes-Redman criteria met at 16 minutes, and we've got some observations that you can see. Blood pressure 115/71, pulse of 70, sats of 98%, and temperature of 36.9. This CTG met criteria at 16 minutes. Now, just personally, when it comes to Dawes-Redman and the use of it, in terms of how long you leave a CTG on for, it is absolutely fine to remove the CTG if the Dawes-Redman has met at 10 minutes. That would stand up in court if you were ever in a situation where that was necessary. However, just with this CTG, guys, I would have recommended keeping it on for a little bit longer, just due to the fact we do have some loss of contact here. And although the criteria has met, I think it's a better idea to get a bit more of an overall picture when we've got a bit more contact on the trace. But yeah, that's just a little side note from me. She didn't have an obstetric review on Hope ward, just because she was going to be spoken to by the obstetric registrar and the team on labour ward when she was transferred over there. So she's eventually moved to labour ward. She's now 37+4. This is the following morning. Blood pressure 112/80, pulse of 69, resps of 16, sats of 98, and a temperature of 36.5. This was her CTG on the first one on labour ward. And as you can see, we do have some accelerations. It looks like when we're looking at this overall, it does look a bit like reduced variability within the first sort of 40 minutes, but it does appear to seem like it's cycling, possibly within that last 5 minutes you can see on the screen here. Although the Dawes-Redman criteria hadn't met at this point, it was recommended by our obstetric registrar to commence the induction of labour. However, the review wasn't particularly documented. I think the activity was quite high at this time. So yeah, ProPress was inserted at 6:44 in the morning, and the client had a Bishop score of 3. Now, something that I wanted to sort of bring up here with this case in particular, myself and Mr. Naguib have both done some research into the best method of induction for our babies that are estimated to be on quite a low centile, because one of the questions a colleague asked me about this was, why would ProPress be the recommended form of induction on a baby we know that is likely to have very little reserves when it comes to contractions in labour? So I did a bit of digging just to see if that is as per sort of protocol, or if we would necessarily recommend a cervical ripening balloon or dilapan in cases like this. And what I found was actually quite contrary to what I thought I would find, in that there's no evidence to suggest from the research that I've read. So please, if anyone's got anything else that they'd like to add to this, in all of the evidence and the research that I've read, it's noted that there's no contraindication to use a hormonal method of induction regardless of the centile from the baby, which I thought was quite interesting, because I don't know where I've got it from. I don't know if I've just completely made it up in my head, but I always kind of assumed that if we had a baby we know had very little reserves, or likely to have very little reserves, like an IUGR baby, that we'd possibly recommend a mechanical induction. But the RCOG, the NMC guidelines, and all of the research papers I've read on the BMJ have all said that there's no contraindication to use a hormonal method of induction, which I found quite interesting. And there's no link between that and anything like increased problems with delivery or increased issues in labour that I found. But if anybody wants to point out anything else that they've read, please do let me know. And if anybody finds a paper, then send it along. But yeah, just thought that was quite an interesting point here, because I know there's so many grey areas in obstetrics where we think, oh, should we not? We induce, for example, VBACs with things like a Cook's balloon just due to the risk of scar rupture and that kind of thing. So yeah, and just if anybody fancies a quick statistic, the likelihood of hyperstimulation, which obviously in a baby that's quite IUGR for PROPES induction is 4%. So of all the women that we put PROPES as a method of induction, there is a 4% chance of hyperstimulation, which we'd obviously be much more aware of and more cautious of with a baby that's IUGR than one that's a term neonate. So yeah, just to add a few facts in there for you. Go on, Mr. Niggy.
Yeah, so just to add as well, in Croydon, we don't use PROPES for VBACs, but I must admit the main method of induction of VBACs in St. George's when I was there, and it is still there, is PROPES. So why did we stop using PROPES for VBACs in Croydon specifically? Is because we had 3 rupture uteruses in a row in one of the years. So it is completely non-evidence based. It is completely one person came to his head that we shouldn't be using PROPES for VBACs because of the ruptures. But in areas in St. George's, for example, when I was there, we had 2 ruptures from PROPES and nothing was stopped. So again, there is no contraindication in using PROPES or Prostant for induction of labor in VBACs. But for VBAC, for IUGR, for any method that we think there will be a maternal or fetal compromise, we need to be very, very, very vigilant into its effect. As Cara said, 4% hyperstimulation, and I wouldn't consider always any baby to be like going into HIE only with hyperstimulation, but sometimes only stimulation, like normal contraction in a baby on itself, without, as we can see in many of the HIE babies, are on a normal vaginal delivery on birthing center, for example, they were contracting, So we are not talking about the hyperstimulation itself to cause the HIE, but yes, contraction itself can make the baby suffer because it cuts more or less or decreases the blood supply. So, but PROPES on its own, as Cara said, there is no contraindication, but everything in medicine should be used with moderation, with attention. Going for a hysterectomy, normally for a fibroid uterus, is legitimate, but when you go into a hysterectomy for fibroid uterus in a previous 5 laparotomies where you anticipate bowel injury, you need to be cautious. You can't say hysterectomy is contraindicated in a previous multiple laparotomies, but everything needs to be put in context.
Thank you, Mr. Naguib. I should also point out, this was, I'm part of a network of fetal monitoring midwives, and, every single trust deals with incidents very differently. And what I think you've just made like the perfect point. We had incidences where we had VBACs that ended up with uterine rupture, And as a result of that, as a sort of part of a QI project, we decided to use only a mechanical method of induction instead of a hormonal method, just due to the fact that we'd had these ruptures. However, I then sort of question when it comes to our creating of guidelines and the creating of guidelines in multiple other trusts, whether or not the care provided to the women that had those specific incidents failed to recognise earlier on signs of rupture or anything like that, because rupture obviously can happen very quickly. But better monitoring, this is not me saying that this could have absolutely been avoided at all, but I wonder if more of an in-depth look into the care or the regularity of observations or CTGs could have then prevented us changing our guideline to one that's not necessarily recommended by any further research other than that's sort of found within our trust. And I think a lot of trusts across the UK, if they have incidences in specific things like for example, using a mechanical method of induction as opposed to hormonal, just swapping and changing that is obviously gonna, it may make some of a difference. However, looking a bit deeper or doing a deeper dive into the care provided to those women and the level of monitoring they had, whether or not doing more frequent CTGs or more regular observations, whether or not the support provided to the staff on that particular shift, if they've got other human factors that are happening at the time, whether or not we would have discovered something slightly different about why these ruptures were happening. But yeah, that's obviously the reason why we do that at Croydon. That's not something that I believe is going to change anytime soon. But yeah, it's definitely something that we can look into and trial. And the same obviously goes with this case, because I have seen it before where we have used a mechanical method of induction for our IUGR babies, and whether or not they had good outcomes or not is another story. But yeah, it's just interesting to see this perspective. So this was the CTG then continued. Obviously, once the PROPES was inserted, the Dawes-Redman criteria was completely invalid, as we don't use Dawes-Redman criteria following on from a method of induction. However, this was obviously continued until the full 60 minutes anyway. But what the CTG did tell you was that the reason the criteria didn't meet was because no episodes of high variation, and the long-term variation was low, I believe, as well. The CTGs then continued on for a little bit longer, as you can see. No major changes here. And then I think this was when it was discontinued. So this is, bear in mind, 7:50 in the morning. So our nice day staff are about to come over and take over the care of this woman. So CTG discontinued, and the plan was made for 4-hourly CTGs just due to the high risk factors, as opposed to our regular 6-hourly following induction. Blood pressure 116/75, pulse of 73, respiratory rate of 17, SATs of 98%, and a temperature of 36.5. We had a consultant ward round performed in the morning. They were happy with the continuing plan from the night team, which was for 4-hourly CTGs. I spelt review wrong, haven't I? Review 24 hours after PROPES, and for a continuous CTG when this client goes into established labour. Is there anything else anybody would like to add or do in terms of the care provided for this woman, or is everybody happy with the plan? It's not a trick question, open to all opinions.
Maybe I would have added, knowing the risks of that specific baby, that once she contracts, to put her on CTG.
Yeah, absolutely. Just being hyper vigilant when it comes to the care provided for this woman. There was also a question about this, again, with our method of induction. I don't know if we've got anybody from other trusts on the call today, because obviously I can't see who's on it. But one of the questions again that was brought up when we reviewed this case was, when we're inducing women, I know that this happens in some trusts, I couldn't name them, but this is sort of heard through the grapevine, that that some people do a regular auscultation in between CTGs for women that are particularly high risk with their induction methods. I don't know, I couldn't tell you exactly how frequently certain trusts do listen into the fetal heart rate. But yeah, that was a conversation that was had following on from reviewing this case, whether or not we should introduce that into our guideline. Although with the current ratio we have on our hope ward for other inductions, our ratio of midwives is 1 midwife to 8 patients sometimes. So I think trying to establish that would be quite a challenge unless the ratio of women to midwife does go down. But that was a conversation that was also brought up. So if anyone's got any evidence for that or knows what other trusts do, I'd be really interested to read that. Perfect. So
Yeah,
moving on.
I
Oh,
have,
go on.
I have, I haven't seen that in any trust I've worked in, Cara, to listen in between the 4-hourly CTG. It will be like
Interesting.
yeah, it would be an extremely, extremely exhausting to any manpower in the world, really.
Yeah. Yeah, absolutely. I can't remember, Miss Inigi, which trust it is that I've heard it from. I promise you I'm not making it up. But I have heard of a particular trust that listens in. I think it's every 2 hours in between CTGs. So essentially they'd listen in at least twice in between from CTG to CTG. But I think they probably have more staff in terms of ratio to patients, so it's not as tricky to do. But yeah, nobody in our Southwest London trusts does it, I believe. So yeah. So this is your next segment of CTG. The midwife reported that this baby was very, very active, and that was the reason for the loss of contact. Again, our observations remain stable: blood pressure 120/73, pulse of 75, resps of 18, SATs of 98, and a temperature of 36.4. They changed her position at around 11:25 just due to that little bit of loss of contact that you can see. Unfortunately, I think when they moved position, the Toco decided to go completely AWOL, but we can see that she's having some tightenings here. And she did report feeling some discomfort with this. So Entonox was provided for this woman just as a form of pain relief, and she didn't want anything else at the time. Just as a fantastic point from this midwife, and I know that if any of you have attended my CTG study day, you'll know how much I waffle on about it. But just when we're writing LOC on the CTGs and we're informing anybody who's reviewing this as it's loss of contact, it's really important that we note what we're doing about it if we are noticing that we're not picking up the fetal heart rate very well on a monitor. Are we changing position to try and adapt to be able to see it better? Are we reporting that babies may be very active and that's the reason why we're losing that contact? And is there anything we can do about it to improve that on the CTG? This is a very good one because obviously they've documented exactly why that's happening. And also it doesn't last for a very long period of time, but we do get the odd CTG whereby we do lose the fetal heart rate quite a lot for a prolonged period of time. So just to sort of add that one in. This CTG was then continued. As you can see here, we've got some cycling. So this baby is showing us all the levels of sleep cycles. So we've gone from being quite active to now probably having our deeper sleep in terms of our reduced variability. And then it picks up again and we've got some lovely accelerations towards the end as well. So this baby at this point is telling us that they are neurologically stable and active and happy at this point. So the CTG was taken off, I think. Yeah, CTG was taken off at 1 o'clock after a good hour or so of monitoring. At 3 p.m. almost, she was given some paracetamol and dihydrocodeine as she was getting more uncomfortable at this point. And she was still using the Entonox as well during her contractions. Now, because of our 4-hourly plan for CTG, we would have recommended this CTG was recommenced at around 5 p.m. or 10 to 5. But because of the fact that this woman was contracting very regularly towards that time period around 4:15, the midwife recommended an early CTG, and the plan was actually made to examine this woman just due to the fact that she was showing signs of very fast progress in labour. When we put the CTG back on, which was obviously 45 minutes early, unfortunately, this is what we saw. So the CTG, the midwife did multiple position changes because there was some confusion between whether or not this was fetal heart rate or maternal, just due to the fact that it was very, very different in picture from what we'd seen previously. The midwife in charge came in for support, and the emergency buzzer was eventually pressed. And the ultrasound that was performed by the obstetrician at 16:23 confirmed that this was in fact the fetal heart rate. Maternal pulse was palpated to ensure that there was two different heart rates, which further confirmed it. And then she was examined, found to be 2 centimeters dilated, and the decision was made for a category 1 cesarean section for bradycardia. My question is, can anybody think of a reason why this baby may have had such a very vast change? Anybody want to comment at all? Everyone's very quiet this evening. No? Okay.
All right. Sorry, Kara, this is Prabhat.
Hi, Prabha.
Hi, my understanding is that, of course, we know that there is a relative uteroplacental insufficiency. So in those fetuses that we won't see the classic features of gradually developing hypoxia, they don't have that adrenals big enough to produce the adrenaline, so that we won't see that adrenaline surge pricing baseline, and that typical the stages of gradually developing hypoxia. So they're already at the end of the cliff. So with a little push, that suddenly you will see this kind of end result. So that's what I experienced in the past.
Yeah, I
Thank
absolutely
you.
agree with you. Thank you. I absolutely agree with you. I think, we've already got a very much compromised placenta and compromised baby. And just, yeah, the likelihood here is probably the fact that her increasing contractions and the increasing strength of the contractions had caused this baby to suffer very quickly. Obviously, the fact that we'd had this CTG on, bear in mind as well that, I want to give massive credit to this midwife that was taking care of this patient, because, I think in some circumstances, more specifically when we're looking after multiple women at once, we tend to sort of follow things by the book and follow this time frame. So this woman wasn't due to have a CTG performed for another 45, 50 minutes. And what could have easily happened here is we could have ended up doing that 45 minutes later, but actually listening to your woman, putting her at the forefront of the care in cases like this is so important. And being able to recognize those changes in behavior had obviously prompted this midwife to start monitoring earlier. So I just want to give a massive credit to the midwife that was involved in this care, because it's very easy for us to fall under this, oh, I'm due to give her a VE in 4 hours. I'm due to do a CTG in 6 hours. She's not due her manual pulse to be checked for another half an hour, that kind of thing. Whereas actually making sure that you're taking into account the overall clinical picture and very much, listening to exactly what's happening within that room is so important when we're providing care to women. So yeah, just a big up for the woman that the midwife that was caring for this lady. The difficulty we've also got with this is that obviously we've put the CTG on at sort of 11 or to 12 minutes past 4, but we don't actually know how long before that this CTG has actually been down for. We don't know how long prior to this the fetal heart rate is down, just because this is the initial part of the monitor. Now, this is not me saying that we should keep monitoring on 24/7 for women that are being induced or even women that are in labour, because, sometimes we're never going to be able to figure out, how long these sort of things last for. But yeah, this was obviously a good sort of example of great teamwork and communication. And this lady was taken immediately to theatre, just due to the fact that obviously we don't know how long this has been going on for and whatnot. The decision was made to do a general anaesthetic for this patient. We got this in terms of CTG, unfortunately. So it was a quick turnaround to theatre. This was an attempt at listening to the fetal heart rate whilst there. Obviously, you can see we only got 2 minutes, but the fetal heart rate was said to be audible between 60 to 80 beats per minute. And that's what was showing up on the numbers on the screen. And then at 16:32, a general anaesthetic was performed and knife to uterus skin. And then at 16:34, we had knife to uterus. Just throwing a few more statistics out there for you. Bradycardia, in 90% of cases, a bradycardia will recover with, a prolonged deceleration will recover within the first 6 minutes, and 95% of prolonged decelerations will recover within 9 minutes. So we absolutely, add in the 3-6-9-12 rule, try and combat anything that we think could be influencing the prolonged deceleration and try and rectify that. But yeah, obviously we don't know how long this baby's had a heart rate of sort of between 60 and 84 prior to this. Also, although the majority of them do recover, just as a key sort of premise is, if you've got reduced variability prior to the prolonged deceleration, if you've got reduced variability within the first 3 minutes of the deceleration, or if the fetal heart rate drops below 60 within the first sort of 60 seconds, those are indications that actually you're much less likely to have a recovery following prolonged deceleration. So if any of those 3 things come up when you do experience this in practice, that is an automatic indication to move to theatre. And actually, research has shown that in those cases, in those 3 particular cases, the babies that are born after 20 minutes of that happening tend to have pHs of less than 7. So there's a little bit of evidence for you whenever you're in practice, just to sort of keep in mind those 3 things are definitely a let's move kind of situation. And we can always come out of theatre. That's the other thing. Mr. Naguib always says this as well. Whenever we go into theatre, that does not necessarily mean that a baby has to be born. It's about reassessing the situation whilst we're there. But obviously, as you can see, we confirmed that this baby's heart rate was still very much low and below 60, and therefore the decision was made to proceed with a caesarean section as a category 1. Would anybody like to guess the outcome of this baby, or the APGARs or the gases of this baby?
Cara, before guessing the APGARs and the outcome, I want to ask one question to everybody, and if somebody has, would enlighten us. Would anybody would have done anything else to this lady in the course of like the last since induction or whatever?
Everyone's going to be silent.
Yeah, no, you can say no, for example, because personally, I scratched my head 100 times to say, oh, I should. Then every time I say something, I cannot find anything I could have done.
I don't think
That's fine.
everyone's gone
We can
silent
guess.
this evening.
I know, we can guess then, no problem.
I would hazard a guess, since no one's making any comments, that they'd probably agree with the plan of care. Everything was very much as accordance to our local guidelines. So, when we're looking at this, we there's nothing that we can specifically pinpoint and say, you know, this wasn't done correctly, or this wasn't following a certain guideline, or this wasn't following any evidence. So despite the fact that, you know, this was not the greatest of outcomes, you know, there's probably not anything really we could have done differently. Mr. Naguib, would you have given terbutaline?
No, because if I'm going for a cut one here, uh, and with no, I would, because I will be delivering within the next 10 minutes, really. No.
Perfect. Okay. Right. Well,
Is there any evidence that we removed the propus?
yeah, they did when they did the VE. Sorry, I should have mentioned that.
Anybody likes to guess? Fine, Cara, put them out of out of misery today.
I will.
It is very cold outside, so
I
maybe
know.
yeah, everybody is under the duvet, but yeah.
Everyone's got such cold fingers they can't press the unmute button. That's what I'm going with. Unfortunately, this wasn't the best outcome for this baby. This baby was actually on the 0.6 percentile, weighing 2305 grams, APGARs of 2, 7, and 8. This baby had very, very poor gases of 6.75 on both arterial and venous, and high lactates. The base success on our gas machine was unfortunately unreadable, so you can imagine this was quite high as well. So I would imagine normally with an episode of like an acute hypoxia, our base excess and our lactate aren't particularly raised, because these are things that, you know, go up over time. But because of the fact that this was obviously going on for quite a long period, then obviously it's built up quite a lot, and that baby's had to go into their anaerobic metabolism and respiration. And then obviously we've got high lactates, as you can see. This baby was born pale, floppy, with no heart rate or respiratory effort. But improvement was made after 3 rounds of ventilation breaths, and chest compressions weren't needed. This baby was transferred to one of our near tertiary units for CFM monitoring and had active cooling, where the baby remained for, I believe, about 7 or 8 days, and mild HIE grade 1 was confirmed. I am very pleased to say that this baby has made a very good recovery since this. I checked before presenting the case to you this evening. Baby is having NG tube feeds, but neurology looks good at this point, which is fantastic. And also, baby is breathing spontaneously with no oxygen requirement or need for anything like that. So just the feeding needs to become established. But in terms of recovery from this, when we see gases of this, like 6.75, this is quite often regarded as being a very unlikely to thrive situation. But with this baby's made a very good recovery, all things considered. So yeah. Does anybody have any questions regarding the case or anything like that?
Cara, just a comment really. I think there's nothing to add during from the time that she was being induced, but I have a feeling that there was a duty of care prior to the decision was made for induction to discuss about the birthing options, both the section and the induction, and explain that there is a higher risk of needing emergency section, knowing that it was a first centile. I'm sure there had been probably had been a discussion, but I didn't see that on the presentation. So that's the only thing, because the Montgomery case was a clear explanation that we had to give the both options, and explain the risk and let the woman to make that decision, really. Yeah, thank you. It was an interesting case. Thank you so much.
You're welcome, Prabha. Thank you for joining. Wonderful. If anybody has anything else that they would like to add, then just let me know. But otherwise, I will see you all next week. I've got another good one for you next week. And then I will be doing, then I have a week of annual leave. So yeah, and I'll be back the week after that.
Thank you very much, Karen.
You're welcome.
Thank you,
Thanks,
Cara.
everybody.
Thank you.
Thanks, Cara.